Hi, hello everybody. Thank you for sticking around. And let's see, I think we're going to start now the next session, which we'll hand back over to Mike Lipnick. And I think, Mike, I heard you're going to try to make up some time.
No problem.
A little bit. So this is the performance testing of Pulse Ox findings, and then talk also about the third-party independent testing capacity. That's 2 sessions, okay?
Sounds good.
Over to you.
Thanks, Mike. So for the next 10 or 15 minutes or so, I'm going to share some of the findings from the devices that we've tested. There are a couple of important caveats, though, that I want to state. A big one is that these are preliminary findings, so they may change once we finish testing the devices in the full cohorts that we want to be testing them in. That means adequate power, sample size, adequate diversity. And so I'm sharing preliminary data, so please keep that in mind. We will start posting this to the website so that you can follow, and we will be labeling things as preliminary versus confirmatory and things like that. So just keep an eye on that. As I mentioned before, we have testing underway in about 50 devices. These are devices that we buy directly from the manufacturers. We usually buy multiple of the devices, multiple of the probes, and are testing them in healthy adult subjects in the hypoxia lab at UCSF. We've done about 220 sessions. In some cases, we're testing multiple devices at the same time in the same subject. Always careful to shield the devices from each other to avoid any potential interference. But that's how we're able to use 220 sessions to generate many more data sets for more devices. I just wanted to share a little bit about sort of how the studies have changed, especially in the last couple of years in terms of how we've been thinking about them. For a very long time, the sample size that we were using was around 10. This blue number on the left-hand side. The sample size was like 10. 15%, as you saw in the regulation or the guidance from FDA, 15% or 2 subjects, 2 of the 10, should have dark pigment with little definition of what that meant, but that was generally the cohort composition. 2016, we published some findings on fingertip devices showing that a good number of we only tested 6, but several of them in this study did not conform with regulatory guidance and performance despite what was published in their literature for several of these devices. And then during COVID, we were being asked if we could rapidly test devices for different donors. Donors were reaching out saying, we're about to ship 100,000 of these. Have you tested it? In some cases, we had tested it and we would share the data. In other cases, we hadn't. So we started doing testing of more of these. Frequently, they were low-cost fingertip devices was the most common request that we were getting. And in some cases, unsurprisingly, the performance for some of these was really awful. And we didn't have a place to disseminate this on an ongoing basis. And so that was sort of where we came up with OpenOx. Now, when we started the project with OpenOx, we knew we wanted to raise the bar for testing and move away from this sample size of 10 and 15% being ambiguously defined as having dark pigment. So we were moving more in the direction of 25% with dark skin pigment defined by objective measures of skin pigment, those color matching tools to really make sure we had real diversity. Now, whether 25% was the right number or not, whether 24 was the right number or not, we didn't have data to really have more clarity at that point, but that was the initial goal. Now, what's happened in the last 2 years as we've gotten more data and had many more minds thinking about this is that proposals have come about for sample sizes as high as 200 subjects per session, which is a huge change. Diversity of skin pigment has changed from 15% to closer to 33%, which we think is a welcome change and makes sense based on the available data. And then also including not only objective, but also subjective measures. Again, the subjective most helpful for communicating the findings, the objective for ensuring that they're precise and without bias in the actual measurements. That's kind of where we are, but there still is not 100% consensus on where this is, and maybe we'll hear more about that from the regulatory bodies. This is the list of devices that we have been prioritizing tests in. This is about 24 devices of the 50 that I had referenced. All of them have 24 tested, which was our initial goal. Now we're aiming for somewhere closer to at least 40 to 80 per subject. And again, 33% with dark pigment defined objectively. In the green column, you can see the total number of sessions per device. So most of them are around 40 to 50, but we still do have work to do, especially if new regulatory guidance has a number that's much higher than that, then we have quite a ways to go. This is price points vary here. Again, from a couple dollars up to several thousand. These are handheld, fingertip, and tabletop devices, so a mix of devices. These were selected with kind of by getting input from people in the OpenOx collaborative community, looking at procurement lists to the extent that we could get access to them for donors and other agencies. And that was how we created, and then also global market share, just knowledge of global market share. So that was where this all came from. We published some of these data with about 6 months ago. One thing to note with this data set that I'm showing here that was published, these cohorts were smaller. These were not the full 40, 50 that we have today. This was from a year ago, so this was the small initial cohort of 10 to 15 max, 15% darkly pigmented. Here we showed that on the left-hand side of the dotted line, which is 3% ARMS, so like FDA threshold, that a good number of the devices were passing, but several devices did not, clearly here. And then we were not powered to draw conclusions about impact of skin pigment, but we did see a general trend when we analyzed the amount of error by skin pigment group, that the darker skin pigment groups, as indicated by the dark lines, tended to be further right, larger error in those groups, but these were extremely underpowered. We are almost powered enough to be able to do that with the new cohort sizes. So full spoiler alert, I'm not gonna be able to share with everybody what you wanna see right now, which is how does every device perform and what's the bias and all that stuff. So if you're sitting on the edge of your seat, it's not coming, but it is in this slide deck, but it will be coming soon to the website. What we do have right now is, sorry for the size, this is again, just to give you a sense, this is what I had shown before. We have a lot of devices that are passing, we have a lot of devices that are not passing, and we have some trends in terms of the groups with darker pigment having worse performance for many of the devices, but it's variable and wide-ranging. Here are some preliminary data on the root mean square error, this statistical metric that is in the regulatory standard. You can see the model in the left column, the manufacturer, the cohort size, the column that's labeled MST-HIJ. This is study participants with dark skin pigment as defined by Monk HIJ or an ITA threshold of less than -30. So these cohorts are not yet, some of them are not yet at the 33% threshold, which is why these are still preliminary results. And on top of that, we don't yet know what the total cohort size is going to be needed to power each of these. So with that grain of salt, you can see the right-hand column, the amount of error is ordered from top to bottom in this cohort, with one of the better performing devices in this cohort with an ARMS of 1.7, and one of the worst all the way at the bottom with 8.2. So quite a big spread. Now, the device at the bottom, it costs $2. The device at the top costs $7,000. So there is a big range here. One thing that I want to draw attention to that's not visually shown here, but if we compare data, or if we compare the result, the ARMS, this error, when we had the cohort size of 10 for the same device, when we now have a larger cohort size and a more diverse cohort size. For some of the devices, it hasn't changed that much. We get a similar finding. But for other devices, it has changed them from being clearly not passing to passing, or clearly passing to not passing.
Sorry, what was that?
That's probably a better way to phrase that. So when we tested, some of these devices we've already tested, we did the analysis when we only had 10 subjects tested in that device. And when we did it, some of the devices looked pretty good. Now that we have something like 50, the same device but tested in 50 people, more diverse, they now don't pass. But we've also seen the opposite, where in one instance, one device with a cohort of 10 looked terrible. And now with a cohort of 50 with more diversity, actually looks pretty good. So there's not a big conclusion to draw from that other than we need to understand why that happened. And so we're digging into the cohorts, but it does speak to this notion that there are more factors we need to be looking at than just the few that are named in the regulatory. Regulatory does not really provide a lot of specification around motion, around the sizing, around the perfusion. There are claims, but there's a lot of ambiguity in how you're allowed to make that claim. So you'll find a lot of devices that say, we're made for peds and we're good in motion and we're good in low perfusion. But like what exactly that means, it's not apples to apples across devices, and often those claims may not be as backed up as we would like them to be. So anyways.
So how do you define the diversity?
So for us, we're focused on diversity of skin pigment right now.
Okay.
So we're not defining diversity of these other factors.
Okay.
We are measuring perfusion, index, pulsatility, amplitude using our own device. So we are not warming the hands. So we end up with a diversity of perfusion, pulsatility levels in our cohort. And then we track things like gender. There's some requirement for gender diversity.
Age.
And
yeah,
there isn't a requirement for age necessarily.
Okay.
It's all adult. And so while there may be differences,
maybe extreme.
It's hard for us to do the testing of extremes because of the safety. And this has come up a number of times. You know, we don't really enroll anybody older than 50.
Okay.
And we don't enroll anybody younger than early 20s. Are there differences that may be seen beyond those ranges? Absolutely. But it becomes trickier when we're basically doing a stress test to somebody. From a safety standpoint, the way to reduce risk maximally is to really make sure that we have the best chance of having healthy subjects, but it's an inherent limitation of the applicability of the results to people who you really want these to work best and people who are not healthy. So we're trying to also account for things like BMI a little bit better than we have in the past. In the past, we restricted it to normal BMIs. There is some relaxing of that to include to include overweight and even lower obesity, but not morbidly obese, like again, safety issues. So we're trying to improve the diversity, but we're going to be inherently limited based on where we are enrolling. Things like anemia, hemoglobinopathies, nutrition status, bilirubin, like there are things that you will find in other populations that are very common, and in some instances may even be safe to do the testing, but we just aren't seeing those. So
we have a question about, is your testing motion free?
Yes, great question. This set of data is motion free. We do have a protocol in the lab where we will do motion testing, but I don't have those data, and we're not doing that for all of these devices at the moment. Crudely, it is a machine that is controlled by a computer that we place the arms on, and the computer will simulate movements that are standardized so you can test different devices. So we'll do vibration and movements and stuff. These data are motion free. Okay. So this tries to visualize what I did not articulately explain just a moment ago, which is that on the top, what you're seeing here is the total, let's see. What you're seeing here is we take the data. If we've tested, let's say 50 people, we will use the computer to create cohorts, randomly choosing from that 50, create cohorts of 24, while also ensuring that we have diversity of skin pigment. So it will create 100 different cohorts of 24 based on the data we have.
Okay.
For some devices, then it calculates the root mean square error, the error here. For some devices, like the best performing device, no matter what cohort the computer generates, it always looks good. And like with a pretty narrow range of good. Some devices, like the middle one, they always look bad. Sometimes a little less bad or a little more bad, but they always look bad. But there are some devices that, depending on what cohort you choose out of your sample, they can look like the best device, or they can look way outside of regulatory standard. And so this is something that we are trying to dig in more deeply. And this is potentially where having more test data, especially independently validated data, might become more important with these devices. So I'll leave it at that. In terms of preliminary bias analysis, we are seeing when we run bias analysis of all the devices on either side of that red line in the middle of each of these graphs, to the right is positive bias, the SpO2 from the pulse ox reading higher than the gold standard value. On the left is negative bias, it under reporting or reading lower. We're seeing most of them showing a positive bias. It is not as clearly showing the bias trend according to skin pigment group, but I am kind of withholding assessment of this until we have more data because we know we need more. But this will be forthcoming, hopefully pretty soon. So in terms of how we're starting to report these data, over the next few months, we're going to be putting these data into the website with preliminary tags. Things may change quite significantly. So, a big grain of salt. I wish we could say, hey, we're done, this is the result, but this is going to be an ongoing process. For those of you who have been to the website, know that on the device data page, this is what it looks like. This is fairly non-technical, trying to report error, a few other elements like lifetime cost. We make lots of assumptions with our lifetime cost. You can adjust those based on your context and you will come up with very different numbers. So, please customize that when you're using it for your setting. When you dig deeper on the product pages, we have added a couple new things recently that will get built out more in the next couple of months. One is, while we're waiting for regulatory to finalize what the standard is, we are going to disclose more specifically for the error number that we calculate, the root mean square error that we calculate, how many people was the device tested in, and what percentage of them had dark skin pigment. And so that's what we're reporting here. This had a error or a root mean square of 2.3%. It was tested in 51 people, 29% had dark skin pigment as defined by Monk HIJ and ITA less than -30. So that's one thing that you'll be able to see. That may not help solve the answer on the procurement side because we need the regulatory to come around and we will eventually become consistent with whatever regulatory is reporting. But for now, we didn't want to keep sitting on data waiting for the regulatory changes. So this is how we're going to start releasing it. But this does not mean that you should conclude this is definitely a good device or this is definitely a bad device, because these numbers, we don't know what that threshold number is going to be. The other thing that we're going to start doing is communicating the data in non-technical terms. So you can have access to all the raw color data that you want, which is arguably pretty confusing, but we will also report for each cohort that the device was tested in, we will show the colors of skin represented by a square in this diagram, a conversion from RGB or Monk, something that is relatable to how human might perceive the color of that individual. It is imperfect for the scientific analysis, but helpful in terms of communicating, was this tested in a cohort that kind of looks like me, kind of looks like my patients, something that, again, we can just communicate, use to communicate. Same thing with things like root mean square error, non-disparate bias, these plots, which are sometimes hard to follow. We're going to try and implement a new color coding system. That won't be finalized until we know what the regulatory standard thresholds will be, and we will you can kind of think of leaving reviews online for a product out of 5 stars, kind of. It will be synced with how the regulatory standards choose to make those. But we'll try and have some color coding system to make it a little bit easier to navigate those data as well. Again, this is probably on the order of a couple of months as we start putting data in there. We don't know, but maybe we'll hear later today when the new regulatory standards will come out. We're going to continue testing as much as we possibly can. With the new infrastructure we have in the lab, this will be possible at least for the next 6 months or so, and then to be determined after that. We'll release the performance analysis as we have it on the website, and then all of these data will go into preprint released manuscripts and then peer-reviewed manuscripts as soon as they're ready. And then again, and this is kind of transitions into the next session, but we know we're going to need to augment the testing capacity of the lab in order to power these studies. And so that's kind of where we are as a next step. So thanks very much for your attention, and happy to pause there and see if there are any questions.
Schooling question. What's non-disparate bias?
A term that's being used to describe the analysis to ensure that skin color, that performance isn't different based on different skin colors.
Right.
It's not intuitive.
Okay.
You're correct.
Just accept it.
Yes. Yeah, that is one of several terms that are being considered by regulatory.
Yeah, so based on your analysis, I'm wondering what you think of using cutoffs for SpO2 to make clinical decisions, because I think, when we were at the beginning of the TNC project and the other projects, that was kind of how we were approaching it. You look at this, you compare the SpO2 levels to your threshold, and then you make a clinical decision. And I'm curious to know, your thoughts on that. Is that something that we should be rethinking? And also wondering, if I guess we have 2 different uses, right? One is using it to make a decision, if you check them once, you make a decision, you refer, you give oxygen, or you also use it for ongoing monitoring. And is in the same device, if they can it perform poorly on one but okay in another? It might be slightly off, but it's good for tracking. So if you're just trying to see if O2 is going up, it's a reliable device to check for changes in oxygen saturation. You might be off by 3% or something like that, but you can check changes over time. So I'm wondering, maybe that's...
And you're more likely to be, according to your data, you're more likely to be above the thresholds in terms of the reading.
That finding conflicts with some other findings,
right?
Though, and so that is of note. The findings that have been in many of the clinical trials, those devices we are testing, but we're not in that data set that I showed. So it is still possible. These are all true. But yeah,
to the main
grappling with the
question,
implications for public health use of PO for child health, for example.
I mean, that's the key question. That is the key question.
For example.
No, I mean, that's the key question.
Yeah.
And I think there have been people who have responded to that by saying, well, maybe we should just err on the side of just using a correction factor and being more conservative. But it doesn't seem like that's possible from the data that we are seeing. That doesn't seem like that's going to be easily possible. Other people have suggested, well, let's just get a blood sample or use multiple devices or all these things. There isn't. The summary answer is there isn't an easy solution.
Yeah.
Certainly, greater awareness and attention to the fact that these devices are not perfect can go a long way. I think there are a lot of people that would reiterate the point that they're not intended to be used as diagnostics, that they are a monitor, that you should be using trends, and everything every monitoring tool, you should be using it in the context of all the clinical settings. I mean, I agree with that, but to some degree, that's a very unsatisfying answer, because that's what we say for everything, right? So then the next question is okay, but what should I do now with the person in front of me? How should I what's the practical advice? This is something that's being discussed a lot in one of the subgroups that's trying to create this educational content. What do you tell the bedside user? the difference between a monitor and a diagnostic is not like a useful thing to say to somebody who's trying to use a device in front of them. The notion of using ranges, I think, is interesting with the exception of like neonates. If an adult is 3% higher or 3% lower, generally there's not a physiologic detriment to that person. Right. The problem comes in, or the problem that we've seen has come in, again, asterisk, in high-income countries, where if you're using it in that way, and there is a bias, and you have a population that has people with dark skin and people with light skin and unlimited resources, and you choose to not give those to somebody because they're 1% or 2%, then you do have a population level health or healthcare disparity. That's what we've seen. We haven't seen the other stuff yet. Right. So I think like in some ways, so gosh, I wish I could answer that question more directly, but I think my response, like the messaging has generally been, people are going to continue using the device in the way that they have, and they should continue using it, but they can do things to make it slightly more likely to give a better reading. And that has to do with like not just putting it on for 5 seconds and seeing what happens, maybe not even doing like measurements in isolation, trends and repeat measures, things like that. But also when they are determining a change in care, like, am I going to admit this person or not? Am I going to give them steroids or not, or antibiotics or not? There needs to be more thought going into that decision than I'm just going to use the SpO2 number. And people got, I think, during COVID, a little bit too fixated on that. It's perfect. We can triage based on it. And so it's so easy to do. Let's do it. You can still use the number, but just don't use it in isolation. Know that it has this error and make care decisions that are tailored. I think there is some safeguards against like care and health and healthcare disparities that can be addressed through that practice.
That's really helpful. And I'm just wondering if there's areas where we would anticipate potential for more harm, like thinking about neonates, and if you get too much oxygen, though it is actually harmful. So like, are there certain populations we should be thinking about, like where there is potential for harm based on like, the reading zones? As accurate and prioritizing and just especially since it's makes so little data in those.
It's a great question. All my research is in adults, so I will be careful with what I say about neonates. And clinically, I, for the most part, dealing with adults as well. There are other researchers in the community that are doing a lot of research specifically in neonates. It's really important. I hope we get more data from them, including skin pigment. Skin pigment in neonates is like a totally different can of worms. It's dynamic and different than adults in many ways. And so I think the recommendations for adults may end up being a little bit different. That's conceivable.
Some really good activity in the chat happening.
One question. For the pulse ox manufacturers, is there a provision apart from the publications that these new technical specifications can be communicated to ensure that the pulse oximeters brought to the market perform efficiently?
So communications to the manufacturers?
Yeah, how are the manufacturers going to use this information beyond just the publication?
Is that a question about the regulatory technical specifications?
Is that from Adina? Adina, do you want to?
New technical specifications is what she says. But Adina, if you have.
How do we communicate?
I can try and address it. Feel free to interrupt me, but I think that communication of technical specifications, ideally there's harmonization, so there aren't like 5 different ways that a pulse oximeter, the community feels like it is reasonably safe and without bias due to skin pigment. Hopefully that comes through regulatory agencies, which can then be adopted or adhered to. Maybe there are additional technical specifications to go into it, but the hope would be that, from my personal perspective, would be that there's harmonization among the regulatory agencies so that this isn't something that has to get independently done. A pulse oximeter coming to market, this is kind of what the data supports in terms of how it should perform, and that donor agencies, ministries of health, nobody has to reinvent the wheel on that we can try and work towards consensus. That may not happen this year, but hopefully over time, that's, as a researcher, that would be my hope, but I can't speak obviously from everybody else. Please.
Do we want to do more chat questions, or can I?
Most of them are statements.
Okay.
So we can answer that question first,
yeah,
and then we can go.
I think it's kind of a related question. So if a manufacturer wants to get their product FDA approved or show compliance to ISO, they can approach your lab to do that, right? That's a function you serve. So how does that type of request differ from the testing you're doing that's going on OpenOx? Because, like, to show that they meet FDA requirements, like you said, there will be 10 subjects and only so many with dark skin. Like, do you take that opportunity to say, we can test your device much more rigorously than that? Are you interested in it? And then the data is going to go here? Like, is that how it works? Or are these two very separate things?
Yeah, so you're correct. Companies come to our lab, they ask if we can do the regulatory testing according to the guidance or the ISO standard. I would say in the last 3 years, companies were already starting to like think ahead to what else should we be doing. You know, they kind of got a sneak peek because in the lab, we are always doing all the skin color assessment and all these other things. And so many manufacturers that we work with were already excited by that and included that as part of their standard or their process.
Right.
So we do offer it. So that is part of, like, we offer larger studies. We offer the skin color methods that we've been working on. Most companies engage with that.
Yeah. And then for the data to end up in the open source database, do you have to like ask permission to share that openly, and are manufacturers quite keen to do that, or do some of them actually say, no, we don't want data up there?
It's mixed. So sometimes companies come to the lab because they want to get preliminary data to help make a better product. So if they come with a device and they're testing a new algorithm or a new piece of hardware or whatever, they may use that data to make a better device, and they don't want it released until, you know, version 1.0. It's done.
Yeah.
The default in the lab is if a company contracts with us for us to do their testing, that is their data and they own it. We ask if they want to put it in the repository, in which case we gladly will. But otherwise, that's the default.
Yeah.
We do ask most companies who come into the lab if they are willing to share the data so that we can test some other devices. For example, if we have a device that's on the forehead, the ear, the arm, the chest, the foot, wherever, they're not even using the fingers, do they mind if we also test devices on the fingers? So we can share in that way. And then some devices that are to market trying to get their regulatory, we will ask, are they okay if we share their data into the repository? And some say yes, and some prefer not. The default for OpenOx testing is that we've created our list totally independently. It's not based on who's coming to the lab.
Right.
We created that list in the way that I described it. We buy those independently and we test them. If they do overlap with a company that is coming to the lab, as a courtesy, you know, I mean, we share everything that we're testing, so there's no secrets there, but we don't ask permission from the companies for devices that are already on the market. So that's kind of how OpenOx tests.
Okay, so if you just
I get
one off
all the devices, all 50 of those we bought independently, and we start testing on them, the list we made independently. Sometimes there's a manufacturer that overlaps with somebody who comes to the lab. But
I see. Okay, so the manufacturer only owns the data if they've come to you
if they come to us. Correct.
Ask. But if you've bought it off the shelf, you own the data. And
correct.
Okay.
There's a comment in the chat that I'm really interested by from Jeff, but then I just also related to the manufacturers. I think we lost Andre from Nanan, but an action item for us to do is ask them, the manufacturers, how they stay updated on these types of things. I think people like Path, when we have projects like this, we generally try to communicate clearly to the manufacturers. but maybe there's other routes, and I think staying connected to the Open Ops community is probably one of the best ways. So we'll follow up on that. But then Jeff's comment, I'll read it for those. I'm really curious about this, if it's a technological fix. The error band is impacted by the correctness of the LED specifications in the probe and the optical properties of the tissue in the, I can't see it, light path. In particular, melanin acts as a high-pass filter in the red region, resulting in an increase of the transmitted red wavelength. An increase in the transmitted centroid red wavelength will result in high bias in readings. So I'm going to translate that to say, is it the light? Is it the bulb? Can we change the bulb and fix it?
The bulb is a factor. And part of what Jeff's getting at also is an important piece, which is that, you know, if we test a device in the lab with a probe, that the same make, model, and probe 6 months from now or a year from now may have a slightly different quality LED in it, either because of a manufacturer change or a part change, or, you know, just quality control. And that can significantly impact the performance of the device. And so that is something that we're looking at. What he's stated there, generally, I think we agree with. We are measuring the wavelength, basically measuring the wavelength of all the devices we test to see, like, what is the LED, how's the LED performing that's in it? And is that what the manufacturer thinks it is? It's hard to sort that out sometimes, but we are looking at that, and we do hope to be able to share that at some point. But it is a very relevant factor, as is kind of aftermarket monitoring of performance.
I have more questions, please. But I don't want to like.
That's okay. I think we're good. Yeah, go ahead.
Yeah, there's no more in the chat. Go ahead.
You said that you were trying to kind of increase the number of subjects that have been tested on devices. Do you buy multiples of the device and interchange them for like inter-device variability?
Yeah, yes, and sometimes we do, sometimes we don't. We don't have enough funding to do that for all the devices. Mm-hmm. We do try to have multiples of all the devices, but we're not doing that exactly. What we are doing is tracking performance over time. So for, you know, some of our devices, some have 50 tests, some have like 150 tests. We monitor the error by session to see if there is any kind of trend suggesting degradation of performance of the device over time. So we do track that. And by and large, we don't see that. It's an idealized condition. I wouldn't say that that is what's happening in the real world, but we haven't seen major problems with that. It's a very relevant point. It is a limitation of our study design for sure. Manufacturers would say, and it may be in future regulatory, that, like, you know, even a reusable probe that's intended to last for a long time should be changed really frequently in the test. We're not seeing evidence to say that, we're not seeing data to suggest that in the way that we're using them for these types of tests, that there is degradation over time. If a probe gets dropped, run over, whatever, we're replacing it. We are very careful with that sort of thing, and that kind of stuff happens. But while we do rotate them, it's limited, but we're not seeing, in our kind of quality checks, we're not seeing an issue for the devices where we have the most data. That doesn't mean that that's going to be true for all devices. Most of the data I'm referring to has been in the handhelds and tabletops. I don't have that analysis for the fingertips yet, which would be potentially where there's the most concern for quality.
Yeah.
So big caveat there.
Yeah.
There was one follow-up question of how are you measuring wavelengths?
Are you measuring what?
Wavelengths.
And they'd be happy to offer their.
Yeah, Jeff, I think we'll circle back with you pretty soon. This summer, we're going to be doing a little bit more of that, and have appreciated your contributions via prior calls, and would love your feedback. We can share with you what we've done so far, and see what your thoughts are. Thank you for offering.
One
last
question about gold standard ABGs, arterial blood gases. have you seen that? I know you must, all of these tests must did it simultaneously at the same time. But have you seen some gaps also? And is it affecting the machine that within 5 minutes, within 2 minutes, something like that?
It's a great question. I mean, the topic of the blood gas is probably like a whole day thing. But so the upshot is, it is possible that if a sample is delayed from the time it's drawn to the time it's run, that you can have a very different result, even on the order of like minutes or seconds. I mean, less than that. We test for that periodically to ensure that our like handling processes are not yielding that. So it's part of like onboarding QC in the lab for new members, just to understand. We don't have problems with that with our method for doing it, which involves very carefully, rapidly obtaining the sample in a certain way, ensuring good de-airing, getting any gas out of the sample, and then how we handle it when we're running the sample, as well as keeping the sample mixed. So if you're not mixing the sample, we see a lot of error very quickly, things like that. So we have sort of a protocol to try and avoid that. So in the lab, the blood gas machine is 5 feet from where we draw the sample. So it's literally, we draw it, we de-air it, and we run the sample. Sometimes there is, a minute delay, there can be. We also are running it in triplicate. So we run a sample and then we run it again and make sure that they agree. And if they don't agree, we run it a third time to make sure that at least 2 of them agree. And if we're seeing a trend, then that all gets thrown out. So we can check against that, but it can't happen, but we do try to safeguard against it.
Great, thank you.
Yeah.
Okay. I think if you want to, yeah, go ahead.
Do you want to have just like a brief discussion on the lab? I know on the agenda, it was blocked for like a half hour, but maybe before we go to the break, we can chat about this issue of the lab testing kind of briefly. John, if that's okay with you. I think I brought up a number of times this issue of our concern that global testing validation capacity may be more important than ever because of the regulatory changes that are going to happen, because we still have a lot of unanswered questions despite a lot of testing. And so moving forward, there's probably going to be a need for increased capacity. On top of that, the issue of having more testing capacity, having some testing capacity that's not exclusively based within lightly skinned population geographies. And so wondering if you might comment on your perspective from the Uganda National Drug Authority as a regulatory, what would be some of the potential benefits of a lab like that, challenges that you envision, how could that be utilized by NDA or more broadly in the region where you are? Thank you.
Thank you, Mike, for that. First, I'm standing in for Brenda, Chitembo, and Rachel. I think you met them earlier in Uganda and had some few discussions with them on the issue of setting up the lab. As far as India is concerned, one, it's a mandate to ensure that there's availability of healthcare products that of quality, cost-effective, and performing well. Now, looking at the intention of the lab here, we foresee that to help us in achieving this mandate, and also the lab can be a center of excellence where the region where benchmarking can be done to help research be done, and also we're looking at better management of conditions that are affecting us. We have issues of management of complicated malaria, things like pneumonia, the real problem, and we feel like having these devices the country will help in the better management of these conditions. As NDA, we're also looking at making policy changes, but based on data that comes out of the lab. If there is data that can prove that certain policies can be changed, then we can use that data to inform our policy at the national level. Thank you so much.
Thank you, John. Before we wrap up, any final comments or questions?
Yeah, just wonder if there's any comments from the folks online about challenges, or because what we're considering is an independent testing lab like the hypoxia lab, but based in a low and middle income country. Makerere is Uganda is the proposed location because of a close partnership with the hypoxia lab and a very strong anesthesia department. And so the thought that I had was that it might be helpful for local manufacturing to have testing capacity within the continent at least. But I don't know, anyone has a pre-lunch comment on that or question? Freddie, you were first.
Yes, thanks. No, I think I agree with you. I think that there's a lot of discussion about promoting local manufacturing of medical devices, and there are teams that are trying to innovate in that space, like the biomedical engineers, and some of whom are also associated with UNICEF. So having a lab, I think, in addition to the benefits of being able to have a more diverse sample, study population, there are also those other benefits. What I wanted to touch is capacity for the regulatory agencies, because at least, again, I'm not a regulator, but we have John and Brenda and other colleagues online. I know that regulating medical devices is new. In a way, it's behind the mechanisms for the medicines. I don't know whether there's room for capacity building, so that is also strengthened alongside this local capacity, which then also brings in the issue of strengthening the procurement guidelines, because a lot of this is very, very technical stuff. So being able to say that specifications for this are supposed to be this because of the reasons of access, quality, and eventually contributions to better health outcomes. I don't know if this is the space for that discussion or somewhere else. Ricardo is laughing.
Is there space for capacity building or regulation of medical devices as a whole? Oh, Brenda, I see you have your hand up.
I wanted to supplement John and Freddie on their submissions. And the first one being that I think Uganda and the region would benefit first in a way that the agencies would be allowed to utilize the resources that they have to do other things, because as we all are aware, setting up a lab requires some kind of heavy investment, which I think not any of the agencies is currently willing to invest in. So having an independent lab, I think kind of relieves that burden, and most of the agencies and manufacturers can be able to depend on that lab. I also think that because Uganda is a center of, it's a research hub for the clinical research, this lab will come in handy because it will enhance as well as facilitate the research and development of the new technologies in this Pulse Oximeter. Still, in addition to what Freddie said, the capacity building and training, I think, will also come in handy, being that Uganda is centrally located within the region. So most of the other countries, Ethiopia, Kenya, Congo, Rwanda, can be able to tap into the resources that are being set up. And also, I think right now we have one person who has indicated was applied for assembling of these pulse oximeters within Uganda, and we, I think, finalizing the reviews and authorization. So having this kind of lab, I think, would be handy, because right now what we're telling the person is, please go to China, please go to India and have this thing tested, and you can give us the results. So having a lab that is centrally located and within Uganda will definitely go a long way in informing the decisions that we make. Yeah, that's my submission. Thank you.
Great. That's really interesting that there's someone that's applied to assemble pulse ox in the region. I did not know that. Okay. Beth?
Yeah, my question was about, for the lab, is there like an accreditation that's required or some kind of like ISO standard that would have to be met? Is that a barrier to setting these up in new locations?
Yeah, it's a good question. There is an ISO standard for this type of lab, a broad umbrella for, and we've kind of gone through the process of exploring whether it could be done in Uganda or the region. There's precedent for it, and it would be possible based on kind of our exploratory work so far. So yeah, we would aim to adhere to that, and then we would basically do, not to get too technical, but we would do the validation of all the equipment, personnel, methods in San Francisco, then have like a training that goes back and forth, and then quality control that goes back and forth between the labs to ensure we're getting similar results on an ongoing basis in subjects that are in both locations or in certain cohorts. So, but yes, there are some standards, there are some additional things that we would implement